Hi everyone, my name is Dr.Mazhar and today I just complete the urology second lecture as already first lecture I completed. So this is second lecture of urology about renal calculi or renal stone. So first of all, I would like to talk about the causes. Then I will talk about the stone. So these you can see in the picture the few causes like dietary deficiency of vitamin A somehow lead to the formation of stone and altered urinary solutes. When solutes become so much or altered solute level, so it can induce stone formation. When decreased urinary citrate, so this is also lead to the formation of stone when citrate become less. Renal infections like recurrent UTI can lead to the formation of stone. Inadvertent urinary drainage and urinary stresses. So if someone have urinary stresses, like if male patient have BPH, so by bipolar prostate hyperplasia, they can lead to the urinary stresses and individually finally lead to the formation of stones. Prolonged embolization from any cause like paraplegia or any injury to the spinal region, like in the lumbar region, you can say lumbar region. So it can induce the damage, the some innervation to the kidney and kidney function become disturbed and hyperparathyroidism. What's the normal physiology? The parathyroidism is the one which regulates calcium and vitamin D level. So when parathyroid hormone activate, so it can cause bone, you can say breakdown of bone and calcium come into the blood. So that calcium then filter into the glomerulus, and then they reabsorb and more less reabsorb and more can lead to the formation of stone. So this is the thing. Even sometimes thiazide diuretic can lead to the formation of stone because thiazide can retain calcium inside the body. Now this is about the kidney stone. You can see in the picture, this is a renal pelvic, this is a pyramids, this is a renal cortex, and this is a calyx, minor, and this is a major calyx. So here is a stone formation occur. This is a pelvis and this is a ureter. So in this ureter, there is a formation of stone. You can see in this picture as well, kidney stone in the minor calculus. This is a major calculus. The stone formation happen here and then they come in the pelvis. So this is a cut section of kidney. Okay, what's the types of renal calculus, that how many types of renal stone? So there is a 4 or 5 major types that can lead to a formation of stone. Oxalate calcium. Oxalate calcium is a stone which formed due to when you take so much, you can say vegetables, it can lead to a formation of stone. So it causes bleeding. Why? Because due to its sharp projection. So when that stone passed through the ureter, so it damaged the endothelium or inner lining of the ureter and they can cause bleeding. Then phosphate calculus. What is the phosphate calculus? Calcium phosphate is smooth and that phosphate calcium formation due to the phosphate. So that stone that formed due to the phosphate because stag on calculus. So this is formed in the renal collecting system. Then uric acid. So uric acid and urate calculi. So uric acid, if you know the biochemistry, in the biochemistry there is a purine metabolism. So end product of purine metabolism, hypoxanthine, then to and then the uric acid. So it is an end product of what? Purine. Purine present in the meals like in red meat. So these are smooth and often multiple. So excessive uric acid can lead to the formation of gout. So if someone has uric acid problem, maybe the kidney failure, kidney not working very well, and then there is a formation of gout in the metatarsal filling joint in the foot. Then cystine calculi, then xanthine calculi. So these are the few calculi that lead to the formation of stone. So this is the stag hand calculi. You can see in the KUB ultrasound, KUB X-ray. So you can see in the stag hand calculi. This is a picture of stag hand calculi. And this is a calculus stone within the lower pole of left kidney. See in the small, this is the calculus. Now, what's the clinical feature? Now we will talk about the clinical features of renal stone or nephrolithiasis. So, silent calculus. What's the meaning of silent calculus? That the some stone, even large, like a stag calculus, that cause no symptoms, but they are progressively destroy the renal parenchyma. So this is an enemy. You can say is an enemy of our body. So it can cause destruction without causing any symptom. So pain is leading symptom in 75% of patients with urinary stone disease. So in the clinical feature, I would like to add more thing that there is a maybe unilateral or bilateral flank pain. What is a flank pain? Flank pain is a flank region between your ribs and your iliac crest cone. So that area we call what flank region. So patient complain of bilateral flank pain or unilateral flank pain. So this is a very important thing that you must differentiate. And that stone, if stone present in the kidney, so pain may be radiated towards your like your in the female in the labia majora or minora in the external genitalia and male in the towards your urethra. Okay, so this is the thing. Then you see fixed pain. The pain it may be hematuria, maybe pyuria, and if you ask the patient when pain aggravate, so patient complain when I'm doing walking and when I'm climbing the stairs, so pain radiate. So this is the anterior side. This is how pain radiate, and this is the posterior side how pain radiate. So this is the thing you must understand. And then we do eliciting severe tenderness. Okay, this is what we call costovertebral angle. So we do some we palpate and tap the you can say posterior lower abdomen just to ensure either it's a kidney pain or muscular pain. If this eliciting tenderness is positive, this is a confirmed maybe it is a kidney problem. Okay, so this is a on examination how you do in the percussion. There is a rigidity of lateral abdominal muscles. Keep in mind, lateral abdominal muscles are the lateral muscles of abdomen, but not rectus abdominis. Why? Because rectus abdominal muscle is the anterior muscle of abdomen. And when you do percussion over the kidney, like in the posterior of the lower abdomen, you found there is a tenderness. Then there is a renal calculus. So this is the some you can see symptoms increased incidence in male hematuria, pain radiating flank region, sharp, sudden, severe, maybe intermediate depending on the stone movement. If stone move, pain radiate. Okay. And this is the investigation we do, like plain X-ray, we do KUB region for checking the location of stone, ultrasound of KUB. If you are not sure, then we do ultrasound KUB and intravenous urology. We pass a dye through vein and they travel through the vein, enter in the kidney, and then they give us a picture. Okay, and then radiological interpretation that opacity on plain X-ray. If you found any opacity on the plain X-ray. Your diagnosis DDX differential diagnosis may be calcified mesenteric lymph node, gallstone, foreign body in the alimentary canal, or calcification in the wall of vein in pelvis, and calcified adrenal gland. Okay. So this is a calcified mesenteric lymph node. Calcified mesenteric lymph node. So your diagnosis may be DDX like if you found any calcification. So patient, so right renal stone, right ureteric stone, left renal stone, left ureteric stone. See many stones. So this stone is very common nowadays, and this is the calcified adrenal gland. Okay, adrenal gland is very above the kidney. Okay, so this is a dye in ureter and which drain to the bladder and dye filled with bladder in large stone emitted by dye carrying the kidney. So we pass dye just to ensure that there is adrenal blockage. Then what is the treatment? First of all, there is a conservative management. Then there is a surgical management. This is a you can say medical treatment. So calculi if stone is smaller than 0.5 centimeter, They are likely to pass spontaneously unless they are impacted. If stone stuck anywhere in the ureter, because there is some normal physiological junctions, physiological sphincter, you can say that in the ureteric pelvic, and when ureter cross the internal iliac artery or iliac fossa region, there is some sphincter, physiological sphincter, as like in the upper esophageal sphincter, lower esophageal sphincter, same like in the ureter, in the pelvic uretary junction, and when the ureter pass the internal iliac arteries and when they enter into the bladder. So if stone is stuck anywhere, it cannot pass. But if not stuck, they can easily pass. Then we use up antispasmodic and painkillers just to avoid the pain. Antispasmodic just to relax the muscles, and analgesic just to avoid the pain. Then we use antibiotics like we can use ceftriaxone, third generation cephalosporin for avoid an infection. We use diuretics. We use plenty of fluid at early morning to increase osmotic pressure and exercise just to move the stone. Okay. So operative treatment. What is the operative treatment? We do what percutaneous nephrolithotomy. This is a PCNN procedure. We pass a nephroscope through the soft tissues of your loin region and we enter in the kidney. This is the procedure. We use nephroscope, pass through the soft tissues, and then they pass through the renal parenchyma. They take the stone and then they move the stone outward. But every procedure has some complication. If they look so easy, so simple, but its complication is so much. What's complication? It can puncture renal parenchyma and perforation of collecting system, as well as perforation of colon. And then we do ESVL, extra corporeal short wave lithotripsy, just to break down the stone. This is the non-invasive procedure. This some this is some steps like we will not do in a one time. We ask the patient come, for example, to come today, then after week you come, then after week. So this is just like many steps. So we just do this procedure just to take the stone out from the body, because in this procedure we break down the stone and then we give plenty of fluid to the patient, and then in the urine we collect the urine sample to check to ensure either stone is come entering the in our sample or not. Then there is an open surgery like pyelolithotomy, indicated for stone in the renal pelvis. So when stone in the renal pelvis, we do a pyelolithotomy. Then this is a you see pyelolithotomy. This is a pyelolithotomy. We open the pelvis and take out the stone. And then the extended pyelolithotomy. When stone in the posterior surface of kidney, so we do what extended pyelolithotomy. Then we do nephrolithotomy. If there is a complex calculus or stone branching into the most peripheral calculus, it may be necessary to make incision into the renal parenchyma to clear the kidney. This is how we do open nephrolithotomy and open pyelolithotomy just to take out the stone. And we do partial nephrectomy when stone in the lowest calyx, you can say calyx, with infected damage to the adjacent parenchyma, we do what partial nephrectomy. When nephrectomy indicated when kidney has been destroyed by obstruction and infection associated with stone, particularly when there is a pyonephrosis. It's an emergency condition. Pus in the kidney, we do what nephrectomy. Okay. This is the ESVL procedure we do, and this procedure just to uterically is common. See, this is very important thing. Okay, I just would like to highlight, and I will tell you what's the importance. They said that ureteric colic is common after ECL. Why? Because after ECL, when you break down the stone, then this stone will pass through the ureter. Maybe after this procedure, some stones stuck in the ureter and they lead toward ureteric colic or ureteric stone. So for Then stent should be placed in ureter to drain the kidney while stone fragmented pass. Stent mean we pass DJS, double J stent. We pass after this procedure. Or sometime we do what? We do URS, uteroscopic plus intracorporeal lithotripsy plus double J stent. We pass this stent just to relieve the obstruction from the ureter. So when we did this procedure, URS, ICL, DJs, this is the collectively we do in one patient. This is not a different procedure. This is a three steps do in one procedure in one time. Okay, so we did this procedure. After this procedure, we do ESVL. We ask the patient, maybe you need this procedure just because we do this procedure when we do URS, ICL, and DGS. So some stone we just push to the kidney. After that, we do ESVL just to take out the stone from the body. But sometimes we do what we do. First of all, we do ESVL before doing URS, DGS, and ICL. Before this, we do this, and if stone stuck in the ureter, then we do URS, DGS, and ICL. This is the thing you must know, and this is the ESVL procedure. That's how we do. So that's all, guys, for venous stone, their pathophysiology, their symptoms, their medical treatment, their surgical treatment. I hope you guys understand. So this is about venous stone. So thank you for now. Now in my next lecture, I just talk about in the next few surgical topics. Okay, thank you.